My name is Emmanuel Mignot, and I'm professor of psychiatry and the Craig Reynolds Professor of Sleep Medicine at Stanford University. And I've been working at Stanford for over 35 years in sleep medicine. I came from France, as can my accent betrayed. And initially I was trained as a pharmacologist. So I did an MD in psychiatry and a pharmacology degree. I was interested in how drugs, impact the brain and how they could regulate mood and schizophrenia and psychiatric disorder. And then I decided to spend some time at Stanford to look at sleep under the guidance of Dr. Dement and Dr. Mignot. And I moved there and I started to work on narcolepsy, and I've never stopped since then. So I like to say I'm like a muscle. I find a rock, I'm just like attaching to it and I don't move. And I just work. So when I came to Stanford, I didn't really realize what narcolepsy was completely. I was more interested in the drugs that were acting to control the symptoms or sleepiness, etc. But then the more I learned about the disorders, the more I realized that it was really a unique opportunity to learn about sleep in general, that maybe finding the cause of narcolepsy could lead to all kinds of other things we don't know about sleep. And in addition, I also started to meet patients with narcolepsy. And I was really fascinated to see that nobody cared. I mean, you could talk to neurologists and they would say, oh, I've never seen narcolepsy. I don't know what it is. It doesn't exist, And I was saying, but it's weird because there's this prevalence study. Even at that time, Dr. Dement, for example, had done a very simple study, which of course was not perfect, but he had done an ad in the journal, which were describing the symptom of narcolepsy, and a control ad with something else. And then he calculated, how many people responded to both ads, and then brought the people who responded for narcolepsy to the sleep lab, and then did all the sleep tests. And at the end, he found the prevalence of narcolepsy to be 1 person for 2,000, and that's still about correct. So I thought that there's a lot of people that must have narcolepsy that are not diagnosed. And indeed, honestly, this was a struggle until we found the dog gene for narcolepsy, and that gave it a big boost when suddenly narcolepsy, the cause of narcolepsy was found. But before that, it was a struggle. Nobody cared, and many people were telling me, oh, I've never seen a case in my life. So I was thinking to myself, yes, you have seen cases in your life, but you just never recognized it. and even big professors of neurology and chairman the numbers, they don't lie. I have the tendency of believing in science. That's maybe a problem nowadays, but when the science says it's about 1 person for 2,000, 1 person for 3,000, and it was well done in different studies. In Finland, there were a very nice study that had been done on 15,000 people. They asked questions about cataplexy. They brought everyone that was positive. They did the sleep study. They also found 0.03%. So it was clear it was not like super frequent, but it was affecting 1 person for 2,000. So that means, 40 or 50,000 people in America, and it's not negligible. So I got interested in trying to solve a concrete problem, patients, and also, the idea of finding the cause of narcolepsy was a bit of a holy grail of finding the cause of a disease that really affects the brain and disturbs sleep. Because, the other disease that we worked at the time was sleep apnea, but, some people could argue that sleep apnea is really not exactly a disease of sleep. It's more a disease of breathing during sleep. It's a bit the same way you separate urologist from nephrologist, So kidney doesn't work versus a tubing doesn't work. And not to say that they are not both important, but if you want to go at the brain mechanism of sleep, narcolepsy seems to be a unique way to get at that. And interestingly, they had these dogs with narcolepsy who had been discovered before I came by Dr. Dement and Meryl Mittler and others. And they were discovered by chance. Dr. Dement, who was really a force of nature, had discussed about different sleep disorders First, of course, he was interested in REM sleep because he was involved in the discovery of REM sleep with Kleitman in the 50s in Chicago. And then when he moved, it was very natural. And then they discovered quickly after that a lot of the symptoms of narcolepsy were due to REM abnormalities. So, of course, he moved to Stanford. And the first thing he did is to create the first clinic to see patients with narcolepsy, because that was a REM disorder, and that makes sense with everything he had done. And that's when he did his first ads in the 1970s and realized that it was not that rare. But still, it was not frequent enough to sustain a real clinic. So he closed the clinic and then tried to convince Dr. Mignot to come, who was much more interested in sleep apnea, where he immediately kind of realized that was much more frequent. And then they reopened the clinic, a couple of years later, I think 71, 72. And then they had the first clinic where they were seeing both patients with narcolepsy and patients with sleep apnea. And obviously, there were a lot more patients with sleep apnea, so it became successful. And when I came, it was many years later, and Dement had already, established a sleep clinic. It was one of the mecca of sleep. It was the best place you could go, and a lot of people who have sleep clinics now all over the world have been trained there. Of course, I immediately got interested back in narcolepsy because they had this dog model. And the way the dog model had been discovered is one day, Dr. Dement was talking to the American Medical Association meeting, and he described the symptoms of sleep disorders and narcolepsy. And someone said, "Oh, I have a dog with that disorder. He seems to fall asleep all the time, and when he gets excited, he gets paralyzed." So he was very interested, but unfortunately, that dog had already been euthanized. But that gave him the idea of trying to contact all the veterinarians and find others. It was very bold. That was one of his many qualities. And he basically kind of tried to talk to all the vets, and the vets said, "Oh, yes, I've seen a dog like this, I've seen a dog like that." And then they got a few dogs. And then the idea at the time was that narcolepsy was genetic, which was largely wrong. The problem was sleep apnea is so common that when you have someone with narcolepsy and you ask, "Do you have anyone in your family that is tired and sleepy?" They were always, "Oh, my grandfather falls asleep in his soup. Oh, my husband, he snores a lot," because sleep apnea was not known. So a lot of the familial narcolepsy were really not true. They were mostly because a lot of other people who have sleepiness. But still, the idea gave him the idea of trying to breed the dogs with narcolepsy and try to see if you could get puppies and you could get a genetic transmission of narcolepsy. And the first dogs, we came from all kind of breeds. The first one was called Monique, a French poodle. But when I came, there were Sam. Sam was kind of a miniature poodle. There were Beau, who was a dachshund. There were Vernie, that was like a standard poodle. Tucker, that was kind of a mixed breed. I now remember all the dogs. There are like 6 or 7, and they've been bred together, but they had not transmitted narcolepsy. And then in 1977, before I came, then someone contacted them with several dogs affected in Dobermans. So then they had the hope that maybe in Doberman it was genetic. And indeed, they crossed the Dobermans together and they all developed narcolepsy. And they found also a breed of dachshund that also, Labradors that also seemed to have narcolepsy in a genetic manner. So when I came, they had developed this colony of narcoleptic dogs. They had a few sporadic cases, like dogs with many different breeds that had been adopted. And then they had this narcoleptic Dobermans and narcoleptic Labradors that they knew when they bred them all had narcolepsy, and it was a single gene, but they were a bit less affected than the others. And so initially I came, and since I'm a pharmacologist, I tried to see, can we try to use these dogs to find better drugs to treat narcolepsy? So basically what I did is I was using amphetamines, I was using modafinil, I was using antidepressant, and even new antidepressant to try to see if they could make a difference versus the old treatment of narcolepsy. And that was really a lot of fun. We were working with the dogs very late. We're giving them some drugs. And then there were tests that we had invented for cataplexy where we gave food. So we put little food on the floor. It was called the food elicited cataplexy test. And then the dogs were all excited. They enter the room, and boom, they will collapse because they had cataplexy. And then we'll time the cataplexy, the number of episodes, in eating the 12 pieces of food. And then we'll give them medication, IV or Peros, and then we'll test them 2 hours later and see if their cataplexy increase or decrease. But a lot of those were new medications that were not even available for human use. And at the time, it's unbelievable, but you could actually call the pharmaceutical companies and you tell them, oh, you have these drugs that you have reported in these papers that's very specific for the 5-HT1A receptor. Can you give me a little bit for my experiments? And it was a courtesy. They were always giving it to you. Now, of course, there would be 25 lawyers, 250 reasons not to do it, and it would be impossible. But, at the time, it was good. The only thing is so they were saying, of course, we give you the drug. And then I was telling them, okay, I need 3 grams. 3 grams, my God, because they're dogs, it's not like mouse. And, but usually I would get the drugs. So in fact, I received, for example, venlafaxine before it was even released as a drug. And I immediately saw that it was very effective in cataplexy. So that's why I proposed that this would be a good drug for the future to treat patients with narcolepsy. And that's one of the ones we use. Or, so I use all kind of new stimulants. But at the end, it was nice, but it was not getting me anywhere. It was telling me, oh, these drugs increase narcolepsy, this drug decrease narcolepsy, and maybe they work on the symptoms by changing norepinephrine or serotonin for the antidepressant and cataplexy, dopamine for stimulants, but it really not getting me that's the cause of the problem. And then the cholinergic system seems to be involved, very important for REM sleep. But it was just like not telling me what's the true cause. That's why, the second part of my career, I switched and I decided to look for the gene for narcolepsy, which is a perfect timing for a break. And another question. So initially, you have to realize when I came to Stanford, first I was not talking a single word of English, So I could barely understand what people were saying. And Bill, I don't know if you remember, but he was like, he was mumbling a lot. So even for normal people, it was speaking perfectly English. It was difficult to understand. So for me, I didn't understand half of what he was saying. So I was definitely not a leader of sleep medicine. I was just a little rat postdoc that he barely knew. But then little by little, as I started to learn English, I was very well trained in France. I went to very, very elite school, which are very, very difficult to enter. But of course, when you don't speak the language, you are a known person. Actually, I think that's something that I feel very strongly. Right now, often we have people from China, and sometimes they don't speak well. And it's very funny how the administration, we talk a lot about, diversity and inclusion, but, at the level of skin, the color of skin and so forth, but at the level of people being able to communicate well with the English, I think it's really bad. Like, for example, I see how the administration treats the poor Chinese, if they don't speak well, they're just like nothing, they're dirt. I think that's really something we should do improve. Anyway, that's a parenthesis, but I was not speaking well English, so I was just more an observer, and it was interesting to see how it was working in America. So at the time where the ESM and the SRS were created, I was not really involved. But of course, little by little, I went to the APSS meeting. I got my diploma for sleep medicine. I'm number 380, I think, something like that. So I'm like one of the early ones, but not that early. And I started to know about these organizations. And of course, I was a very strong supporter. And very often I would be called to work on narcolepsy task force. And I always responded present because that was very important for the field. Of course, this is really essential to to develop a field to have strong organizations. And including making sure that the doctors know what they're doing, because you have to also realize that the field of sleep medicine didn't even exist. So you had to try to establish some standards so that we don't have some kind of quacks that say, oh, you can sleep under the full moon and you are cured for narcolepsy. So I think you needed to have smart people go together and figure out what were the standards, how we should proceed. And Dement and Mignot and many others did that very well. But I was not involved in the beginning. I was more involved later, when it was already increasing a lot and they needed more expertise about narcolepsy. So some of the issues were, for example, like the acceptance of stimulants. A lot of times people were very reluctant about using stimulants. Was modafinil really safe? And all these kind of questions about, making sure that people realize that stimulants and antidepressants were essential to the treatment of these patients, and they were not like just addicts. That was the kind of things I was doing. Also, of course, we started to realize that some people were wrongly diagnosed with narcolepsy. So we had to establish better criteria for narcolepsy. So I was very involved in this task force to define what is narcolepsy and what is not narcolepsy, which we still need to revise today. And also at the time I was invited to discuss more like basic research aspect of sleep. I always have been a very strong advocate of basic sleep research. And as you probably know, we traditionally had these two organizations, the Sleep Research Society and the American Academy of Sleep Medicine. And that was definitely a strength in our field because they were working together, but they were also a little bit like in a marriage of convenience. And sometimes that created tensions. I was the president of SRS at some point, and the clinicians were all coming to the meeting and bringing a lot of money because they were the one attending the meeting, but the researchers were also bringing something different, a qualitative, maybe better designed, some kind of research. And often there were a little bit of tension, how the money should be shared, how they should benefit different members. At the end, it's a little bit like an homeowner association, I guess, You have to figure out a way to make everyone happy. And it worked quite well and up to this stage. And I think that's one thing that has been very important for the field, is that both researchers and clinicians have worked together. And I think that's one of the things that made our field successful. Bill, to come back to Bill, his dream has not been realized. He wanted sleep to be recognized as a separate medical discipline and have a department of sleep. I tried myself that at Stanford and I failed. And his point was that sleep is a true discipline because we have our own patients, like sleep apnea, etc. We have our own disease. Nobody will claim that they are not sleep disorders. And then there is a body of basic research. So that's for him define what should be a coherent field that maybe would benefit from a separate administrative unit. And he fought a lot at Stanford to try to make that a reality. And that was one of the big things that I think even to this date at Stanford is one of the strengths of our program is we have pulmonary medicine, neurologists, surgeons. I mean, wherever people come from, we don't discriminate. Everybody has to work together. It's the same patients, and we have to make sure that it looks from all these different angles. Unfortunately, I suspect that this is not going to continue because the tendency now administratively is to reconsolidate everything in departments. And so I don't know, but these are like pendulum, one day everyone was talking about interdisciplinary research and everyone wanted to programs that tear apart the relationship between departments. And now it's all complicated, the opposite, all the money goes to department and the department chair have all the power. So Bill was also very involved in trying to change the sleep field in a ways that will ensure that everyone, independent of their specialty, would have a seat at the table and that it will not be fragmented. And in that, I guess, we did not succeed. And I feel still bad about it because I don't see this happening in the next 20 years. I think a lot of time they were doing things together, and sometimes there were regularly some tensions, and the tension were around money, because again, it's very complicated. Like the ESM always had like 5,000 members and the SRS had 10 times less. So obviously it was like the sleep medicine, the ESM was saying, oh, we bring all the money. And then the researcher were saying, oh, you're a piece of crap. You don't even know what you're doing. You're doctors, you're not researchers, and you should have us. I think I was in a very good position because I was both. I always have been a very strong advocate of basic research, and also I care about the patients. But, it's not very easy to be in that position, unfortunately. And generally, in my opinion, we were working well. It's like a family. We're fighting a little bit, but at the end, we're all coming together to meeting. We're always finally agreeing on something. And it was going well. And sometimes competition is healthy, And sometimes the SRS will have a good idea, and the SM will say, oh, I'm going to do it kind of together. And sometimes people were pissed off, but at the end, more is always, I'm always for competition, personally. I think the new motto in science is to share your data and have as many people as possible that replicate and extend in what you are doing. The death of anything is when nobody cares about what you're doing. It's not like trying to be better than someone else. It's making sure that you are recognized and people continue on whatever you are doing, and that we make progress. So I think that has changed. This competition has largely disappeared in science. It's much more about being heard because there's so much more to do. And it's sometimes difficult to even decide what to do and what not to do. Yeah, there's one more thing that I want to point out that I think has been always very important and that we still have problem with, is how to train the next generation and get good people. So I was also involved in the National Sleep Research Center, and every few years, because it was mandated by Congress, thanks to Dr. Dement, he kind of created this independent sleep center in NIH. But the only thing they were mandated to do is to do this 5 years plan every 5 years, but there were no money associated with it, but at least was forcing people to get together and write a document, even if it was not binding. And every time the key issue was we need to make sure that the next workforce is present and that it's diverse and well-trained. And I think that's still a problem we have. We still don't have enough people who are, well-trained in sleep medicine, well-trained in basic sleep research, and can kind of continue to work in that area. And I think the SRS, for me, that was really exciting because I could also, help to foster, new careers and new students in maybe a more effective ways than just, in my own lab. Christian was a very outstanding individual. And, like Bill or like I or everybody works hard, and maybe we all have our negative and our positive. Dr. Dement, I'm sure you know that Christian, coined the term sleep apnea. He came in the 70s and he always was super passionate about sleep apnea. And he was really a genius in terms of finding the things that are important for the future. And he would really he was like bubbling with ideas and always giving other ideas and publishing and so forth. And I think that was his strength. He was always at the forefront of new ideas and seeing where it goes. It's a little bit the same as Dement in some ways. For example, he started to work on sleep medicine and sleep apnea in children way before everyone else. He was always at the next frontier, always asking the next question. What happened when people don't decrease the oxygen saturation but still wake up? He developed this upper airway resistance syndrome concept, which of course correspond to very mild sleep apnea, which we know exists, of course. The question is whether or not you should make it a different disorder, or is it a continuum? So he had hundreds of ideas, and most of his ideas were correct and very in advance. But also he was a little bit of an older generation where, you can take 20 patients and you describe a disorder, and that's it. You are done with the work. Now it doesn't work that way. You really have to get hundreds of patients and do very rigorous statistics, to really prove something. And I think, for me at least, that's better. The standards are much higher, but of course it's also more difficult to make a difference because you need larger studies. So I see Christian as like an ID generator, mostly. And then he was able to show that his ideas were correct in very small samples. And now we see that very often he was correct because he was super extra smart. But we also have to take some of his research with a grain of salt because it was often done in very small sample, and it was what he was thinking, and then he was just going to say what he thought was going to be the result. But it was a little bit of a man another time, more like the classic doctors that see patients and want to describe a new syndrome. In the 19th century, I don't want to say it was in the 19th century, but, like people describe the Guilleminot disease or whatever, and this time has passed. And I think he was a little bit in that trail end of this kind of research where what you do is you really describe a few cases and you just describe a new disease. Not that much, trying to look at the population and have a more unbiased approach. But of course, you can still read this paper and find inspiration for ideas. And it's very interesting because, some of these old papers, amazing. I mean, even in narcolepsy, you can read paper of 1937 and you get some ideas. I have a colleague of mine, he's very famous. His name is Steve Quake. And he developed a test to be able to diagnose chromosome trisomy 21, with a blood test. And the way he actually made a lot of his research breakthrough is to look at old paper. He realized, and when you isolate and all the white blood cells and the red blood cells, and you look at the plasma that stays, even if you do it very cleanly, there is all kind of DNA and RNA floating inside that is not. So he started to look at what's called cell-free RNA and cell-free DNA. And by sequencing that, you find all kind of information about the entire organism. And he found that in an old paper of the Compte Rendu de l'Académie des Sciences of 1950, that actually you can measure DNA in plasma even when you do it very cleanly. So I think you can learn a lot from history and looking back at the ideas generators that are created by all these people that have done this earlier work. And Christian, definitely, it's a literature not to miss. Yes, I think, I guess one thing that I learned from Dement was a little bit different for Christian. Christian was more French than me, and in the sense he would be more complaining about everything that's wrong. I'm French, but I think I'm a little more optimistic. And in that sense, I'm a little bit more Dement-like. So I always directed towards the future and what I think is really positive. And what I see is we are in a period of great transition for the ESM and for the SRS and for everyone, because artificial intelligence and all these new techniques are going to change completely the way we do things. So there's two possibilities. We can resist it or we can embrace it. Probably the best way is to embrace it, but at the right speed. And the question will be, what is the right speed? Just today, I gave a talk about, the idiopathic hypersomnia and explained the limitations of the MSLT. Everyone knows that we have to change that, but how we change it and at what speed is really the difficult question. And I think there's a lot of work that the organization needs to do to prepare the people for the future. And it's a very difficult area because if you go too fast, it can produce problem. You have patients who have diagnosed, suddenly they don't have a diagnosis. If we destroy the MSLT, suddenly people who had narcolepsy without cataplexy, maybe the insurance will say, oh, the American Association of Sleep Medicine says the MSLT is crap. So this guy doesn't have any disease. He doesn't even need any treatment. So of course you can't really do that, but people will misinterpret whatever you say. And then if you go too slowly, then you block the possibility of finding new biomarkers that will replace the MSLTs, that will make it more broadly accessible. So I think it's a very interesting time, but I would think that the ASM should very carefully think at what speed they want to change things. You know, like have a plan over 10 years and really implement it over 10 years. And one of the problems of the ASM and the SRS is that the president change every year, and often they just like have this very narrow-minded view. My job is to make sure the Congress works well and that everyone is happy, and then I just do a little bit of noise and I'm happy. That's not enough. I think, like presidents, we should make sure that as an organization, we try to look at the future and implement more long-term changes. And that's extremely hard. And I don't have a solution, but this is really what needs to be done. The organization that represents the sleep doctors that take care of patients with sleep disorders